This is Dr. Stone-Gale, and I'm going to just do a mini lecture on Otitis Externa as well as Otitis Media. When we think about the pathophysiology for Otitis Externa or swimmer's ear, the auditory canal, the external auditory canal itself is very warm, dark, and prone to becoming moist, so it makes it an excellent environment for bacterial and fungal growth. The skin is really very thin there. And so the canal can easily be traumatized by exposure to moisture, by skin conditions such as chronic eczema, or by infection of a hair follicle, or by trauma from maybe a fingernail, something like that, perforation of a tympanic membrane. And the common pathogens which are involved in otitis externa are Pseudomonas, Staph, or Strep. So Pseudomonas is the most common gram-negative, and Staph or Strep would be the most common gram-positives. There's also a fungal pathogen which can be present, and that in itself can be related to Aspergillus, which is the most common fungal pathogen. And then also Candida would be another fungal pathogen. There's also a viral component to this otitis externa also. These patients present with a rapid onset of ear pain. They have intense itching in the ear. They may have some purulent discharge. You may see some crusting of the ear drainage on the outside of the ear. They'll have some swelling and redness, and there's times when you cannot even get the otoscope in their ear because it's so swollen and you're not able to do anything. You can't even move the pinna. There'll be tenderness at the tragus and the pinna. They may have jaw pain, which is referred. And with the bacterial, you'll see more white mucus, but as they get into the fungal, black, grayish, like a fluffiness to the look of the discharge. You may see some yellow. I don't see that a lot, but I do see the fluffy white, black, and gray. The management of otitis externa consists of a few different things. Usually it's not necessary to go ahead and culture the patient because it's not really going to change your plan of care. You could remove cerumen either manually or with irrigation if they've got some impaction there and see if that will help too. If they're a diabetic, though, you need to be very cautious because if you irrigate a diabetic with water, then you run the risk of developing malignant otitis externa. And that's a medical emergency in a diabetic, so in anybody really. So you don't want to have that happen. So, think about not irrigating them with water. Anti-inflammatories, Tylenol for pain will help. And then thinking about antibiotic treatment. Once the external auditory canal has been cleansed as much as possible, then if the swelling's severe, topical antibiotic therapy should be started because topical agents can be placed in direct contact with the bacteria. So the use of non-sterile versus sterile is what has to be considered. If they have a perforated tympanic membrane, you do not want to put in anything with hydrocortisone in it. So ciprofloxacin would be out, myosin, polymyxin, hydrocortisone, otic solution would be out because they both have the HC in them. With the neomycin, it can produce permanent hearing loss due to cochlear damage, so you don't want to use that. With the Ciprodex otic solution, it is a sterile solution, so if they've got tubes, you can use it. If they've got the otitis externa, you can use it. And ofloxacin otic solution is one that can be used with a tympanic membrane perforation, and also if they have tubes, you can go ahead and use that. Avoiding swimming for 10 days. You want to make sure that they do know that they shouldn't be swimming. And if they do want to go swimming, then they need to put earplugs in their ears. But it's highly recommended that they don't. What are we going to do for prevention of reoccurrence of this problem? The prevention of reoccurrence of otitis externa really consists of avoiding the many precipitants that have been discussed and treating an underlying chronic dermatological issues. So if they've got chronic eczema, that needs to be treated. If they've got any type of infection in the hair follicles, that needs to be treated. This is really important for patients with unusually viscous cerumen because a narrowed external auditory canal can really cause somebody to have problems. So prevention is important in patients who perspire excessively, particularly in water sports, and they're in sports regularly. We need to think about that. After bathing or swimming, the external auditory canal should be dried using a hair dryer on the lowest heat setting. They also want to make sure all the cerumen is removed. The canals become more vulnerable to infection when there is cerumen. Therefore, if there's been any sign of trauma from putting a finger in the ear or especially if a syringe has left the canal wet from doing the cerumen removal, then you need to think about making sure that gets dried out real well. If they swim regularly, then they should use a barrier to protect their ears. So using earplugs, they've been shown to predispose the ear canal to otitis externa. So sometimes we recommend them, sometimes we don't. Parents with, patients who do have acute otitis externa should preferably abstain from having any water sport activities or for at least 7 to 10 days. And no Q-tips should be used or any other foreign bodies. Although otitis externa has a variety of causes, there are some principles of evaluation and treatment that allow management. And, otitis externa is a disease process, and it should be treated aggressively because it can have significant. So now we move on to otitis media. Acute otitis media can be a viral or a bacterial infection in the middle ear, and it's the most common infection in which we prescribe antibiotics for children, but we also need to look at this with adults too. Otitis media with effusion is a middle ear effusion in the absence of acute infection. So with acute otitis media, you're going to see a rapid onset of signs and symptoms of inflammation in the middle ear. They are going to come in most likely with fevers. If their fever is over 102.2, then that's usually with moderate to severe pain, then that is usually severe acute otitis media. If their temperature is less than 102.2 and they only have mild otalgia, then it's usually not a severe otitis media. If they do have a recurrence of their acute otitis media, it would be if they have equal to or over 3 well-documented separate episodes in the past 6 months, or greater than 4 episodes in 12 months, or even greater than 1 episode in the past 6 months. This here is a really good picture of a patient who has otitis media, and you can see how it's erythemic, the tympanic membrane is bulging. So this is a real good view for you to see. Otitis media with effusion is thick or sticky fluid behind the eardrum in the middle ear, and it occurs without an ear infection. So there aren't really any signs and symptoms of infection that you see when you do look in the ear. The eustachian tube connects the inside of the ear to the back of the throat, and this tube helps drain fluid to prevent it from building up in the ear. The fluid drains from the tube, and then it is swallowed. So otitis media with effusion and ear infections are connected in 2 different ways. After most ear infections have been treated, then a fluid, which is called an effusion, remains in the middle ear for a few days or weeks. But when that tube is partially blocked, then the fluid does build up in the middle ear. And that's when the bacteria inside that ear becomes trapped and begins to grow, which then leads to an infection. So when I tell patients too what it looks like when I'm looking in the ear, I tell them if you've made green beans for dinner the night before and you're going to put them in the refrigerator for tomorrow and you put saran wrap over them and you take them out tomorrow, you'll see that condensation, those bubbles, that fluid behind your saran wrap. And that's kind of what it looks like when you look in the ear. And that's what I kind of give patients an idea of, because they really don't understand. When you tell them they have fluid in their ear, they think they're able to get it out, and they can't get it out. On the other hand, there's chronic suppurative otitis media, and this is a chronic inflammation of the middle ear and the mastoid cavity. There's the clinical features of this are recurrent otorrhea through a tympanic perforation. So the tympanic membrane has ruptured. There's conductive hearing loss, and it may vary on how much hearing loss they have. The the underlying pathology is an ongoing cycle of inflammation, ulceration, infection, and then it granulates. And then acute infection of the middle ear causes irritation and inflammation of that mucosa of the middle ear. When then there can be destruction of some of the surrounding structures, and there can be a lot of different, complications with this type of condition. Otitis media is the most common condition for which antibiotics are prescribed, and many have non-bacterial causes. In adults, it accounts for approximately 20% or less of the cases of otitis media. Some of the risk factors involved are smoking. That's one of the big ones, because secondhand smoke can cause problems. The recent upper respiratory infection, male gender, a family history, if they've had previous antibiotic uses, allergic rhinitis, upper respiratory infections, as I said. So some of those are significant risk factors for developing this. Adults are more likely to present with ear pain and drainage and decreased hearing and pharyngitis. And when you do the exam on the adult patient and it's normal, then you need to think about looking at, assessing the teeth, looking at the transmandibular joint, their nose, their pharynx, their cranial nerves, because these are some of the things that could be going on too, which are mimicking otitis. Management of these patients, when you're looking at the treatment goals in acute otitis, it really includes symptom resolution and reduction of reoccurrence. So most of the time, pain management is important in the first 2 days after diagnosis. You can give oral analgesics. You can give mild to moderate if they're having a lot of pain. So Tylenol, anti-inflammatories, local heat for management, as well as myringotomy and, swallowing, asking them to swallow so they're not getting as much eustachian tube dysfunction. With severe ear pain, looking at narcotic analgesics with codeine. They may need to have a Vicodin. They may need to have something with codeine to just get them through. Antibiotics, really you have to think about the decision to treat with antibiotics. They don't relieve pain in the first 24 hours, so you really need to supplement them with something for pain. Usually 24 to 48 hours before you'll start to see that pain come down. So if they have severe acute otitis media, you do need to treat them. And, usually treating them with amoxicillin or augmentin or azithromycin. Those are usually some of the options that you have. If you start out first line with amoxicillin, your dosing would be 500 milligrams for 5 to 7 days, or you could do an 875 milligram twice a day for 5 to 7 days. You can think about using cephalosporins, the macrolides. So when you do get into the cephalosporins, you're thinking about using Ceftin or Rocephin or Omnicef. But usually the macrolides usually work very well too, as the azithromycins, clarithromycin, those type of medications.